Great, thank you. Great. So welcome everybody to this session of the Paediatric Society Lunch and Learn. It was set up for those people with a special interest in child development and disability. Just a little bit of background on the Paediatric Society. A reminder for those of you that haven't come before that the Paediatric Society is an organisation of health professionals working to progress the health, to progress the health and well-being of children and tamariki and young people rangatahi throughout Aotearoa, New Zealand. The Paediatric Society offers opportunity to engage with other professionals. There's some funding for training and education grants. Last session that we had, we put out an expression of interest for other people to come and join us in the Lunch and Learn, and we've met with a couple of other people, but we're really keen for more people to be involved. This is a great opportunity for learning some skills about your development, networking at professional level, so we're pretty keen for people to contact us. So just the last slide for me, please, Estelle. So you'll see there the blue link at the top, the Padlet page. There are, if you click on that, sometimes there are blocks with DHBs, but that's where we have questions from the participants, and you can go back there, and sometimes the presenters go back and answer the question. The second link is that it's a place for you to sign up, get regular emails from our group, and also to join our mailing list for if you've got any further topics. Our next presentation will be on the 13th of July, and Fee Graham is going to be talking to us about knowledge translation. If we can just swap the slides over now while I introduce our next speakers. So today we're very fortunate to have Nicola Wilson, an orthopaedic surgeon, and Warood Al-Zahar, sorry if I've said your last name wrong, Warood, who's a research officer. And both Nicola and Warood are part of the research team working on a Starship Foundation funded rehab project on selective dorsal rhizotomy in New Zealand. So Warood, if you'd like to share your screen, I'll just welcome you both. Thank you so much for presenting to us today.
Well, thank you for the introduction, Jane, and I'm going to make a start. It's a pleasure to be able to present part of our Starship funded research program today. And I'd also like to thank our co-authors, so that's Dr. Catherine Edward, Dr. Iwai Lim, Dr. Anna Mackey, Dr. Sian Williams, and Professor Stott. If we go to the next slide. So I think, as most of you will be aware, selective dorsal rhizotomy is a neurosurgical procedure that involves cutting the dorsal nerve roots, and it's a permanent method of spasticity management. It's actually been around since the 1960s, and it was in the 1980s that Professor Peacock modified the technique and it became a little bit more popular. But really over the last 10 years, it has had quite a lot of resurgence, and many of you will be aware of children in New Zealand travelling to St. Louis for the procedure. So I became interested in doing further research in this area, as I thought there was a lot of discussion in New Zealand around selective dorsal rhizotomy, but not a lot of New Zealand data about what was actually going on around the country. So we go to the next slide. So as an overview to the project, it had four main parts. So the first part was a case note review, and this is an in-depth look at New Zealand children who've had selective dorsal rhizotomy. So that's including their medical history, details of the surgery, and services that they have accessed. So this study has HDEC approval and a locality approval for most of the district health boards, and we request consent from families to participate in that research project. The second part of the larger funded project is the physiotherapy survey, and this is what we're going to be talking about today, so I'm not going to give any more detail yet. The next one is service provider interviews. This has AREC approval, and we're still recruiting for this project. Eligible participants are those service level providers or their delegates who either oversee, direct or manage a service that currently offers post-SDR therapy in New Zealand. So I'd like to thank those who are already involved. And if anyone else would like to join, could they please contact us? We're also interested in knowing services who do not provide post-SDR rehabilitation. So that's also useful. And our contact details are on the final slide, or you could let Jane know and she could put us in touch. So I'll hand over to Warud now, who's going to talk a little bit about the design of this survey.
Thank you, Nicola. Hello, everybody. So the physiotherapist survey was a neat part of this project. It aimed at understanding physiotherapist practices, pre and post SDR interventions for returning families across New Zealand. The aims were sort of further broken down into the physiotherapy time provided and the frequency of sessions, use of guidelines and protocols, including how therapy is tailored, communication and referral interactions that happen throughout the journey, and the final aims related to barriers and enablers in implementing future SDR therapy guidelines, and also a look into regional variation. The survey was aimed at New Zealand physiotherapists who had either provided post-SDR rehabilitation or who were interested in it. And the survey development was as per sort of standard. It was iterative with piloting and constant refinement. It had 5 sections, as you can see there. They closely mirrored the aims. So the service provision, it covered, it covered the hours and the frequency of sessions provided. Participants provided information about any guidelines or protocols that they used, if any, and how they may have modified the therapy over time as the child's needs may have changed. Communication and referral covered communication with the families and also with the overseas clinic who had provided the SDR to the family. We collected information about participants' preferences for educational materials and also general demographics. The survey went out through professional networks, and it allowed for snowball sampling so that we could reach as many of eligible participants as we could. Of the 21 responses that we received, 16 of them had sufficient information. Most of them had 100% completion, so we included those for analysis. And for that reason, for completion reasons, we excluded 5. So we had 33 questions in total. Took 10 to 15 minutes to complete, and Nicola will take us through what the participants said.
So the first part was around service provision, and this was looking at how many children they had provided post-SDR rehabilitation. So of the 16 people who responded, 5 had not been involved in provision, and so they were interested in the topic. So I thought it was interesting, the reasons that they weren't involved, quite varied. From the family could not afford the therapy, so we would assume they're private providers. The family did not ask for the service, workforce limitations, and then for some people, they felt it was out of scope. For the 11 who had provided post-SDR rehabilitation, the average was 2 to 3 children over a 5-year period and a range of 1 to 6 children, so small numbers. Next slide. So this is a busy slide, and I'll just take a little bit of time to introduce it. So in the time periods down the left, these were chosen as they align to the UK guidelines on post-SDR rehabilitation. So I'll discuss some comparisons later on. We then have in the number of sessions on the far column number involved. So that was the number of physiotherapists who responded to the questionnaire that were providing physiotherapy during that time period. And then we gave the average as well as the minimum and maximum just to see the variety. So as you can see, not many people provided the discharge to 3 weeks post-operative, and that would probably not be too surprising to people. Most commonly, people had the 4 weeks to 4 months, or 4 to 6 months. And once again, a range from kind of 1 to 5 sessions in that earlier period, and 0 to 3 in that 4 to 6 months, but on average sort of 1 to 2 times per week. Quite interestingly, in that 12 to 24 period, the average was sort of 3.73, and once again quite varied. So from a minimum of 1 session every couple of months to a maximum of 12 sessions in a month. And one of the things with the small number of respondents, we weren't able to sub-analyse on kind of region or type of provider. So this just gives us kind of an overview of the range that's being provided. So go to the next part. And once again, there were some quite valuable comments, and one was it was variable over the last 5 years. And I think probably people would acknowledge that practice has changed over that 5 years, the way services are provided. And another comment was children offered 18 session in blocks over time. And so that would make it, perhaps a little bit more difficult to analyse the data in those sort of wider brands that we used. It's often interesting to see what the physiotherapists feel the family's focus of the therapy and also the rehabilitation goals are. Strengthening was kind of the major one, followed by functional activities, and interestingly, gait retraining. It was still quite common. Go to the next slide. One of the things that we were interested in is how had families engaged with New Zealand providers? Were they aware? Was any kind of communication going on? And we found that 7 had met the child before, and 2 had not met the child before. So it seems more like there was some longitudinal knowledge of the child and family in providing this rehabilitation. In terms of guidelines and protocols, the majority had no workplace guidelines for post-SDR therapy. A few had some and that could be improved, and some individuals had what they did, although it wasn't a workplace guideline. In terms of resourcing, the majority of respondents felt their workplace was not adequately resourced, and then we went into some of the barriers as to why they couldn't provide this post-SDR therapy. We divide this into sort of 3 major themes. Firstly, system factors, funding, the FTE within the service, and then the way the service is structured, as in the MOE restrictions. Clinical guidelines. One person felt there was lack of clear guidelines, and then also people acknowledged there was potentially patient motivation or patient factors, so motivation in the long term, and then access in terms of distance to therapy. And once again, the written comments provided quite kind of rich information, which you can't actually collect in just responding to a survey. So lack of staff capacity, protocols, guidelines, and long-term expectations from families who've self-funded SDR, and expectations for families regarding long-term goals, and how families kind of maintain that, and patients maintain that focus over a longer period that is required for post-SDR to really get the benefits. Communication and referral was an interesting area. There was good communication from the family, so almost or most of the time the physiotherapist felt the family had been communicating. There was handover from the selective dorsal rhizotomy clinic in most or always of the time. In terms of engagement, however, with the overseas clinician, that wasn't really occurring at all, and that may reflect that the majority of these children were travelling overseas. In terms of communication and referrals, the physiotherapist's perspective was that for the majority, the families were extremely satisfied or somewhat satisfied with the actual SDR procedure, and also, somewhat satisfied in most for the post-SDR rehabilitation. So knowledge translation, all participants thought that post-STR rehabilitation guidelines would be useful. And I think this table was quite helpful in terms of people's preferred method of receiving this information, with e-learning delivered online being the most popular, and kind of wonder if, you know, the whole lockdown and people getting more familiar with being online has shifted this. Conference, workshop or study days was still very mentioned by a number of people. Less kind of preferred methods were the face-to-face in the workplace or face-to-face at Physiotherapy New Zealand. So some kind of discussion points. It's interesting, we had only had a small number of participants, and they provided this type of therapy to a smaller group of children with quite a small range. And so it's kind of interesting sort of thinking about the number of children that have had it. And that most families were extremely or somewhat happy with the STR surgery and also with the rehabilitation. But the most people felt that the workplace was not adequately funded, with system barriers being not just the funding, but also FTE available to provide the therapy. This is what I was referring to before, and probably many of you will be aware there are the NICE guidelines. For those of you that aren't, I'll just quickly recap. In 2013, the UK commissioned several centres to provide SDR under kind of very strict conditions and to carefully analyse the results. And from this, it was felt that SDR was of benefit to children. In the UK, they will fund it for children who are GMFCS level 2 and 3. And they published their findings that led to this kind of I guess, ability to provide this service, but they also put how much therapy they thought it was required for children having post-SDR, and they felt it was different depending on the child was GMFCS level 2 or GMFCS level 3. And I just put in that in comparison to how much therapy we found the children in New Zealand were getting according to this survey. So discharged to 3 weeks post-op. Once again, in New Zealand, only a small, only 2 of the therapists provided any therapy in this period. But in the UK, they say they should be having 3.5 hours per day, and that 4 weeks to 4 months, 2 to 3 sessions, depending on the GMFCS level. And then that 4 to 6 months, either a session once a fortnight or a session once a week. And then from 6 months really to 24 months, it was 1 to 2 sessions per month. I would say there's a slight caveat in this, and that on reading this document, this is in addition to the standard care that these children were receiving. So in the UK, they say, and I'm not familiar with being there recently to know if this is what actually happens for every child with cerebral palsy, but they have an orthotic assessment once every 6 months. They have an orthopedic review once a year, and then they have an allied health review every 6 months. So that's kind of on top of this therapy that's being provided, which I presume is a way of making sure that these children are on track, and if there was any concerns, they could have increased input. So in conclusion, I think it's really useful to have New Zealand data. It is a challenging area in that, you know, it's a small number of children having the procedure, and also a small number of service providers. So we're not able to look or analyse this data in terms of region, because it's hard to maintain anonymity of the service providers. But hopefully this will come out in the service provider research. There is a need for education and resources on post-SDR rehabilitation, and the preferred method of this knowledge translation was using online e-learning. So it'll be interesting to come to Fee Graham's presentation next month on that. If we go to the next slide. So this is our contact details for anyone that wishes to join the service provider interviews. We'd love to hear from you. Any questions? I think a few have come through on the chat. Should I open them
That would be good. And maybe, Warud, if you leave the slide there, because some people may, I know there was a question, there was a comment, I think it was from Catherine, saying that the delivery doesn't come close to the therapy recommendations sent by overseas centres. So I don't know if you want to go back to that slide that compared the UK versus New Zealand levels and then speak to that. Can you take the slides backwards, Warud? Oh.
And so also, Jane, I did just see that Gayla's joined us today, and I know they've been doing quite a lot of work with the CP network. She's leading the SDR stream.
Yeah. Yes. Yeah, I guess, you know, like your comments were, you have to look at this with, you know, with the caveat of that it's just talking about SDR versus, it's very hard to split out SDR versus standard therapy that the child might be receiving. And those New Zealand averages are what you've gained from the participants of your study and averaging it out. And that, I guess, you know, you're right, there's not as much SDR happening, you know, post-SDR rehab happening. And what's your feeling about that, that just in that first 3 weeks post-op, quite rightly, we probably don't see many of those children because SDR is not happening here. So either they're overseas and they're coming back pretty quickly, or they're therapists who are commenting from their time of working with those children. Perhaps some therapists may have been practicing overseas. But to me, the 4 weeks to 4 months and the 4 to 6 months seems sort of within range, doesn't it? Am I reading the slide right?
Yes, and there was some comment on over-servicing, and what I think is hard to tease out is because we do have private therapists, so we can't say it's that I guess DHB funded ones are over-providing, and then also it may be, how do you put in an intensive block? So often the families might do an intensive block where they're doing 3 or 4 times a week, probably 3 times a week, but only for a couple of weeks. And then how do you put that in the average? So a person may have said, well, between 6 to 12 months, yes, we did do an intensive block. So therefore I'm going to answer it in that way, but didn't kind of take it back and average out that intensive block over the 6 months, if that makes sense. So that's why I wouldn't want to say maybe we're over servicing, but
and hopefully those I imagine that some of the participant interviews that who you're recruiting for now may be the same people that participated in the survey, and that in the interviews you'll have more opportunity to gather some of that data explaining that sort of thing. Is that what you're imagining?
Yeah, so the service provider, I think, gives us more an overview of what each service can or is providing, and because it's an interview, you can really kind of drill down into a bit more detail, whereas in a survey like this, you know, you can't go back and kind of say, well, what does that mean? So I think the service provider will be really valuable.
So there's another comment sort of about the intensity of it. There's a question, is there a difference between the number of sessions recommended by private clinics doing SDR versus the UK, where it's under the NHS? Do you know? I mean, you've just compared it to the...
Yeah.
Go on.
Sorry, I have just previewed it to that because that was a nice table that I could find online. I think it is probably different to what is recommended. I haven't seen the recommendations written down. I think that is work that Gayla had done. So I don't know if she wants to comment on that. She's there. I had warned her.
Until Gayla responds, if she's going to. And there's another question. Could you explain the last 2 figures in the... Oh, that was the over-servicing one already.
Yeah.
I don't know if Gayla's going to respond, but I had a question
I am here, Jane.
Off you go then.
I think it's right. There's some comments in the chat about how does it compare to America, and we are mainly guided by what comes back out of St. Louis. And I think the expectations out of St. Louis are far higher than those UK guidelines. So if anybody's had correspondence from St. Louis, which is often not that great, the guidelines are for a lot more therapy than the UK, I would say. I just had another comment about the family satisfaction. How did you recruit the families and ask the families about that? Was that the therapist commenting for the families, or was that the families commenting?
Yeah, no, that was, sorry if I didn't make that clear, that's the therapist commenting on their perception of the family. So I would say that doesn't feel like the feedback we get as clinicians, and I would assume that's probably other people's feelings. So I was quite surprised that it came back so positive.
I think from our clinical network, surveys of families and discussion with families, that they are all very thrilled that they've had the surgery. They've been very unthrilled with the service that they've had from New Zealand. One, the complexity of getting the SDR and getting information from New Zealand, and then the battles that they've had when they've come back about getting therapy and enough dose and therapists who knew what was required. So I think, Jane, you had a comment about scope. Well, if you don't have communication from St. Louis and you've never seen anybody with SDR, how would you know what to do if there's no guidelines? And there's definitely no guidelines in New Zealand. So I think that's why people can feel that they're out of scope, and the demands from the family of what they've been told from St. Louis they should have. So I think there's a real feeling of inequity for those families that have raised so much money and then to come back and have regional differences in their service provision.
Yeah, and I think there's been some good comments around surgery expensive, and then they're having kind of information from where they've privately paid about how much therapy they're getting, and it doesn't relate to what they're getting in New Zealand or, you know, what the UK would recommend, and that feeling of we're not going to get the benefit if we don't get the therapy. So that's really challenging. In terms of the questions around do all DHBs are providing post-SDR rehabilitation, we don't know at this point. We're hoping with the surface level provider surveys that we'll get more of an idea about are all DHBs providing it. You then have to look at how many children within each DHB have had SDR. And that's where I'm saying it's really useful. We've had or invited some services to be involved, and rather than just not respond at all, they have sent back and saying, you know, we actually haven't provided any post-SDR rehabilitation. So, you know, that's useful for us. We can't kind of name them in terms of maintaining anonymity, but it can be presented in a way to say, well, look, these are the number of private providers that are not, and the DHBs that aren't or have not. And it's not that they aren't, maybe they haven't been asked, it's not within their guidelines. So yeah. It's
also possible that families have gone and come back and not sought the services of DHBs. So that's another that the families reported to us, that they knew there was no services, so they just went privately. So it may be that the DHBs just aren't aware.
Yeah.
So can I clarify, Gayla, that as part of the study or the work that you're doing through the CP Clinical Network with the Cerebral Palsy Society, you're almost running a parallel survey of families? Because this presentation, which is, I'd just like to, because it's getting near to the end, say that thank you so much, Nicola and Warud, for your amazing presentation. And it's great to hear all this feedback from physiotherapists. And is there a similar survey going to be undertaken with participants? Because what you've reported in there, I think of the reasons of the barriers, those were reported by the physios, and so I'm just interested if there's a parallel one going to be happening with.
Yeah, so the CP network, we have looked at pre-attending SDR. So our work looked at our families' journey pre-SDR. Nicola's has looked at we've had SDR, and then what's the experience of the therapists during that time, and then the service providers and that. So we have had a lot of consultation with Nicola to make sure that we're not doing the same thing. Yeah.
Right. Right.
And
So and the clinical network, hopefully the next step is that we're looking at working with the CP Society and getting funding to look at the rehab practices as in a day-to-day clinical, what is anybody providing intensives and what does it look like? So different than what how Nicola's approached it. So that's the next, looking from an economic basis.
So not guidelines, more like just finding out the experience. Because I guess if you look at Fee's comment here that it's in the chat about it being important to consider the potential for bias from the source of the clinical guidelines. So if we were to, we don't need to reinvent the wheel in New Zealand and to think about, well, here's some guidelines from the NICE guidelines, and then there are guidelines from the people that are actually doing the surgery. And then it's translating that to actually how it might work in New Zealand. It's like a soup, isn't it?
Yeah, and the CP Society had at one point thought about funding some research, just talking to families who'd had SDR. And then I think COVID hit, and I'm not sure where they're up to, because I think that would be really powerful to actually ask families who's been through the journey how they have found it. But as far as I know, we'd had some meetings about doing it, but it's not sort of ever eventuated. But I think that would be really good to do some research just with the families. It's also quite challenging now because the borders are closed. Yeah. Yes.
So I don't want to stop this amazing chat, and I wondered if some of these questions we might be able to put them in the Padlet page, and Nicola and Warud, I'll put your contact details in the Padlet page as well for people to go and have a look at. And it's been amazing and great discussion and all these questions that are here. I don't know, is it possible, Estelle, that you can save them, screenshot them or something, and we can post them in the Padlet page? And I thank you all very much. Again, feel free to contact Nicola and Warud directly, and come back again on the 13th of July for our next little presentation on knowledge translation. And I hope you all have a great rest of the week. Thank you so much.
Thanks very much, Jane.
Thank you.
Thanks, Nicola and Warud. Thanks, Jane.
Welcome. Thank you to the team that got me here today. I've had a few tech issues that might